Experiences of Biologic Therapy in Bangladesh Perspective. The session will be taken by Professor Dr. Sarker Mahbub Ahmed Shamim Sir, Professor of Dermatology, MH Shomorita Medical College, Chief Consultant, Dhaka Dermatology Institute, LaserTreat, Clinic 21 and DHI, President, Aesthetic Dermatology Society of Bangladesh, Aesthetic Dermatology Society of Bangladesh, and Vice President of SAARC Association of Aesthetic Dermatology. He is also the Secretary General of BanglaDerma and Country Representative of FUE Asia. He is also the Honorable Member of Health Advisors Expert Panel and Reform Committee, Ministry of Health and Family Welfare. And the session will be chaired by Professor Abu Hena Chaudhary Sir, Professor, Department of Dermatology, BSMMU. I'd like to request Professor Dr. Sarker Mahbub Ahmed Shamim Sir to please come to the stage and start his presentation.
Thank you, DerBang and BD Physician, for inviting me here. I'll be talking about biological therapy and my experience in Bangladesh. We are the pioneer in biologic therapy in dermatological practice. I have been doing this since 2015. After that, I use a lot of molecules, and I will today discuss about some basics of biologics, importance in dermatology, and my experience. So, before that, I want to ask you, how many dermatologists are here practicing biologics? All senior doctors. Okay. So, what are the biologics? Biologics are the wide range of substances that are produced from living organisms or certain components of living organisms. Biologics are the protein molecules used therapeutically to target the specific points in the inflammatory cascade of various immune-mediated diseases. So what are the biologics? We all know serum, vaccines, toxins, antitoxins, blood and blood components, allergic compounds, somatic cells, gene therapy, tissue and recombinant therapeutic proteins, all are actually biologics. To prevent, to treat or cure the disease with the biologics. So what the history? The first documented uses of the term biologics was in 1912, when the pharmacological editor of the California State Journal of Medicine, Fred Leckenbach, used it in connection with the national healthcare legislation and the control of vaccine production in the US. Isolation of first ever biologics was the insulin in 1921. Second biologics is erythropoietin. So vitamin D, 1927, estrone, 1929, androsterone, 1931, ascorbic acid, 1932, progesterone, 1934. The first monoclonal antibody approved by the FDA in 1986 was muromonab. First biologic approved by the FDA in 2003 for the treatment of moderate to severe chronic plaque psoriasis was the elifasept. So classifications of biologics. It's a boring subject. So classification is monoclonal antibodies, fusion antibody proteins, recombinant human cytokines and growth factors, and intravenous immunoglobulins. So monoclonal antibodies, they are produced by the single clone of cells, work by targeting the specific cell surface receptors. All monoclonal antibody names end with the stem MAB. So all MAB stands for monoclonal antibodies. So please see the slide carefully. So monoclonal antibodies nomenclature. It's chimeric. Chimeric, it exhibits Z. Example is infliximab. That is, chimeric means we all know. Actually, it's 30% murin proteins and 70% human protein. Murine proteins actually come from mouse or other bacteria or anything. And humanized means 10% murine protein and 90% human protein. It stands for zoo. Example is ifalizumab. Human sequence, that means 100% protein from human origin. So it is actually stands for U, that is adalimumab. So immune, orally Li, newly it is L, it's infliximab. And interleukin, it stands for key old, now the only K, ustekinumab. So this is for the youngsters and who want to understand biologics. So principal monoclonal antibodies are the anti-tumor necrosis factor, TNF-alpha is infliximab. Type of monoclonal is the human mouse monoclonal antibody. Adalimumab is the human immunoglobulin and monoclonal antibody. Anti-lymphocytic fusion associated antigen is ifalizumab, is the humanized Ig1 monoclonal antibody. Anti-IL-17 is secukinumab, human Ig1 monoclonal antibody. So some proteins are fusion actually, that means chimeric. So also known as the chimeric. That means the recombinant proteins also have been produced, the combining human proteins with the bacterial toxins. Actually the monoclonal antibody, it's a game changer. So when the scientists decoding the genes, till today there are 30,000 genes actually decodes and 50,000 proteins are isolated. So fusion protein in which human antibodies are bound to the human receptor ends with sept. Example is etonorecept. Sept stands for receptor, receptor. So ends with sept means it's fusion antibody proteins. So principal fusion antibody proteins are etonorecept and elifacept. Etonorecept is fully human fusion protein and elifacept is recombinant fusion protein. Recombinant human cytokines and growth factors. Recombinant cytokines and cytokine antagonists produced by the recombinant DNA technology used as the immunomodulators for malignancy and the inflammatory dermatosis. Recombinant human cytokines and growth factors, another one is interleukin, interleukin 4, 10, 11. IVIG is a fractionated blood product consisting of IgG antibodies. IVIG is currently FDA approved in dermatology for graft-versus horse disease, Kawasaki syndromes, connective tissue disorder, etc., etc. So what are the importance of biologics in dermatological conditions? First of all, it is a very much targeted actions. Specifically modulates the immune pathways like IL-17, IL-23, TNF-alpha. It's a rapid relief, provides a quick symptom control in severe conditions. Long-term benefits, sustained remission and improved disease outcomes. Reduces the side effects. Steroid sparing, minimize the risk of long-term corticosteroid use. Improve the quality of life, addresses both physical symptoms and psychological stress. Versatile applications, effective in psoriasis, atopic dermatitis, urticaria, and autoimmune diseases. So, what are the biologics available in Bangladesh and what is my experience? So, my experience confined into the 7 molecules like secukinumab, omalizumab, adalimumab, guselkumab, rituximab, tofacitinib, and the baricitinibs. So, all we know the secukinumab, that means Cosentyx. Mechanism is IL-17 inhibitor. Indications, it's widely used for the plaque psoriasis and the psoriatic arthritis. So initial dose is important, 300 milligrams subsequently at weeks at 0, 1, 2, 3, and 4. The maintenance is 300 milligram monthly. Very important. We have to inject it every month, 300 milligram. The patient selection is also important, moderate to severe psoriasis, PASI score +10. patients with joint involvement or the resistance to topical and the systemic therapy. So my clinical experience, it's very impressive results observed with the biologics in severe cases. Doses optimizations. For psoriasis, dose is little bit higher than the rheumatology indications. Sir is here, Atik sir? Oh, he left. Okay. So in rheumatology, in psoriatic arthritis, they are actually for the 150 milligram per month. But what I experiment in biologics, I started with the loading dose 300 milligram. Then after 6 months, I tried the reduction of doses, the reduced to 150 milligram per month with the same outcome. The same outcome. 150 milligram is good. Patient economical burden will reduced a lot. After 12 months, the reduced 150 milligram in every 45 days. Results remain still excellent. And the most cases well controlled. This is my personal experience. The further experimentation I tried 150 milligram every 2 months in some patients, but observed the higher recurrence rate. It's not work. I tried. Omalizumab. It's a mechanism anti-IgE monoclonal antibody. Indication is chronic spontaneous urticaria, severe atopic dermatitis. Dosing 150 to 300 milligram subcutaneously every 4 weeks. Atopic dermatitis is off-label use, typically 300 milligram every 2 to 4 weeks. Patient selection, chronic urticaria unresponsive to antihistamine. We all know for urticaria, antihistamine, and antihistamine. Then the atopic dermatitis with high IgE level with frequent exacerbations. My experience, applied 150 milligram every 45 days after the initial 8 doses over 6 months. Result is very impressive. And with significant symptom control. In atopic dermatitis, results are also promising. For adalimumab. So mechanism is TNF alpha inhibitors, indication psoriasis, hidradenitis suppurativum. Doses is 80 milligram initially, followed by 40 milligram every 2 weeks. Hidradenitis suppurativum 160 milligram initially, then 80 milligram at week 2, followed by 40 milligrams weekly. Patient selection is severe psoriasis and hidradenitis suppurativum with frequent flares and scarring. So my experience, 40 milligram every 15 days, results is very good. 40 milligram every 21 days, results remain impressive. 40 milligram every month, results are not good, with recurrences being very common. For hidradenitis suppurativum, extending the dose to 40 milligram every 21 days, results were not satisfactory, with the disease activity persisting. So I have experience with guselkumab because one of my patients, she brought guselkumab from US. Some of his relative, he's a professor of dermatology from New Jersey. He sent the total dose to guselkumab to me, so I have experience on that. So mechanism is IL-23 inhibitors, indications moderate to severe plaque psoriasis. Initial dose is 100 milligrams subcutaneously at week 0 and 4, and maintain is 100 milligram every 8 weeks. That means every 2 months, there is a disease-free period. Then it will continue. The patient selection is patient unresponsive to other biologics with intolerance to IL-17 inhibitors. Actually, that patient I tried with Cosentyx. But with 150 milligram, there is a recurrence. Then she consulted with that professor, and he sent this guselkumab. Very, very good results, extremely good results, and totally disease-free for the 2 months. But due to lack of patient, there is no experimentation actually. If I give it after 3 months, I have no experience. Rituximab. This is very, very good for the autoimmune blistering disease. So it is anti-CD20 monoclonal antibody. Dosing initially 1,000 milligram infusion spaced 2 weeks apart. It's very good. Actually, patients are totally exhausted with the steroids and the azathioprine. So if you give them 100 milligram in 2 weeks apart, only 2 doses needed to remission of pemphigus vulgaris for 6 months. We tried with Kobir Chaudhary sir in Somorita Medical College regularly. So our experience is extremely good, with the maintenance of low dose steroids and only 50 milligram azathioprine. Results are really impressive. Patient selection, severe steroid resistant pemphigus, relapsing case requiring steroid sparing agents. My clinical experience already shared. Results are not impressive when used alone. This is the important thing, because of course you have to give azathioprine, then the results is very good, showing the enhanced efficacy and the better disease control. With 50 milligram, azathioprine is good enough. And we can actually spare steroids on that case. Tofacitinib is a JAK1/3 inhibitors, indications vitiligo, alopecia areata, and the atopic dermatitis. For dosing alopecia areata, 500 milligram orally twice daily, atopic dermatitis 5 to 10 milligram daily. Patient selection, patients with extensive alopecia areata, atopic dermatitis resistant to standard treatments. So my experience for vitiligo, actually, I used tofacitinib mainly for the vitiligo. So outcome is extremely impressive with excellent control of both vitiligo and the associated itching. You know, itching is the major exacerbating factor for the vitiligo, is superbly controlled with the tofacitinib. Atopic dermatitis results are very impressive, providing effective disease control at the recommended doses. For alopecia areata, now I am not actually using tofacitinib for alopecia areata due to the other preferred ones, that is baricitinib. Baricitinib is a JAK1/2 inhibitors, indication alopecia areata, totalis, universalis, and the atopic dermatitis. The dosing is alopecia areata 2 to 4 milligram once daily, atopic dermatitis 4 milligram daily. Patient selection is severe alopecia areata involving eyebrows, scalp, eyelashes, moderate to severe atopic dermatitis unresponsive to biologics. So my clinical experience on alopecia areata, totalis, and universalis, baricitinib is the game changer for these conditions. Results are superb, and highly impressive with the significant regrowth and patient satisfaction. Atopic dermatitis, I don't use baricitinib for the atopic dermatitis and the other indications in my practice. So keynotes, challenges. The main barrier is the cost and patient affordability. Already the company is actually giving us in a very reduced price now. And I have to adapt with these new technologies. Patient assistance program can help them mitigate costs. Careful patient selection will ensure the cost-effective and optimal uses of biologics. Thank you.